All right, well, good morning, and thank you for those who've come this morning to this talk. I know you've got other choices, and we're very pleased to see you here. My name's Ivor Gerber. I'm one of the cardiologists at Auckland Hospital, Auckland Heart Group, and Warren Smith, a long-term colleague of mine. Both of us have a long-standing interest in cardiac genetics and genetic cardiac disorders, and we hope to share some background and some cases with you this morning. So the title of this talk was I Need an Echo for a Family Heart Problem. And this reminded me of the sorts of consultations and comments that we hear from patients who come and see us. And we always take a family history almost exclusively for every patient that we see. And these are the sorts of comments that we hear. Lots of family have died of heart problems. My grandfather and all his brothers died of heart attacks. Or my mother dropped dead of a heart attack in her 50s. And the common theme, of course, is the fact that the patient is very much of the belief that there is a definite history of heart disease in the family, and the term heart attack tends to get used uniformly to describe all forms of death due to cardiac means. But in reality, there's lots of different cardiac genetic disorders, and it's really important to understand the different types. As you'll see later on, it's really important when it comes down to digging into the detail as to how far you need to investigate and manage each patient. And so I've divided these up into three very broad groups. There are conditions of the cardiac myocyte, or the heart muscle. There's conditions of the aorta, known as aortopathies, and then there's the electrical disturbances. And the first two of the myocyte, dilated cardiomyopathy and hypertrophic cardiomyopathy, I suspect you're all very familiar with, are two of the common genetic muscle disorders. And then two less common ones, left ventricular non-compaction and something called ARVC, we certainly see from time to time as well. If we consider the aortopathies, I suspect you've all heard of Marfan syndrome, but there's also others. There's familial thoracic aortic disease, there's Ehlers-Danlos syndrome and Loeys-Dietz. These are less common, but these are also genetic cardiac diseases that can cause dilatation of the aorta, it can cause aortic dissection, it can cause sudden death. And the last group are the electrical conditions, or as we call them, channelopathies. And I suspect, again, you've all heard of long QT syndrome, which would be one of the more common and well-described conditions, but there's also others. CPVT, or catecholaminergic polymorphic VT, and Brugada syndrome, or less common, but also conditions that we see from time to time. And so, as a cardiologist, when we hear the comment about members of a family dying suddenly, and whether or not the patient uses the word heart attack, we do start to think much more broadly right from the outset that until one digs in deeper, you're really not quite sure yet exactly how the patients are dying. And what I haven't mentioned here, of course, is atherosclerosis, familial hypercholesterolemia, and coronary artery disease, which is less of a genetic disease and certainly not something which is amenable to echo, and this topic was meant to be about echo, but obviously also needs to be considered. And so I've just put up these three little cartoons to demonstrate some of the genetics that underlies these conditions. The genetics is a rapidly evolving, it's a rapidly expanding component of understanding these different forms of cardiogenetic abnormalities, and the basic genetics haven't altered too much over the years, but certainly the detail of the genetics has, and the new developments, the new knowledge, not just the new knowledge gained on what's going on, but the new knowledge gained that tells us what we thought was going on wasn't necessarily as simple as what we thought was going on. And so it's created a lot of additional information, but also at times created a little bit of uncertainty about what we thought we understood. But really, a key message I want to get across is that little cartoon about the devil. The devil is definitely in the detail. And as much as it's tempting to try to wrap all of these things up into one little ball, it really isn't, and you've really got to dig down deeply into each individual case and try your best to understand the mode of death for each case that's been described as a sudden cardiac death. And clearly the best way to do that, ideally, with regards to those who have passed away, is with a post-mortem. But before you even get to the post-mortem, there is a more basic evaluation that anybody can do called a family tree. And the cartoon on the left and the other one on the right, the diagram, is really what we do in each and every case. And Warren will go through a case with you to demonstrate how important this can be. The genetic cardiac diseases very often run along an autosomal dominant line, which means that more or less 50% of offsprings and siblings are going to be afflicted by the same condition. more or less, and it tends not to run along gender lines. It certainly crosses socioeconomic barriers. It's a very genetic condition, and so it's important to, when you start to hear the story about grandfather and grandfather's brother and mother and so forth, to draw up a family tree like that. And where things can get, of course, very complicated is when perhaps there's been one's parents or grandparents had 2 or 3 spouses at different time points and had children from different spouses, and then things start to get incredibly murky where there's 6 children but 3 are from the same father and 6 from the same mother, and so forth. And so you've really got to be very careful that you follow the family tree very, very clearly. Now, just to highlight that when you're considering that third group, which I call the channelopathies, that of course does not typically lend itself to echo screening. And so if you're thinking that what's going on in this family is an electrical disturbance, as opposed to aortic or muscle, well, an electrical disturbance has to be evaluated further with an electrical modality like an ECG. And echo is not going to get you very far if you're thinking about a channelopathy or, for example, long QT syndrome as the mode of death in that family. And the ECG on the left is an example of a long QT syndrome, and the ECG on the right is the typical patterns of Brugada syndrome. And so what technology and what technique you use to evaluate the family really does come down to what you think is going on. When it comes to an aortopathy, well, on the left is an echo, and an echo is easily the most readily available, non-invasive, zero radiation, zero contrast, portable modality that can very, very readily, within a matter of moments, tell you about the size of the aorta, as you can see here on the left. And this particular patient's got diffuse dilatation of the aorta. This is the left ventricle over here. That's the muscle, the septum and the back wall. That's the left ventricle, the right ventricle, and this structure here is the aorta. And you simply measure the aorta diameter from there to there, which is the sinuses. You measure from there to there, the ascending aorta. More or less 3.5, 3.7 centimetres would be upper limit normal for most of us. Once you're getting up into the high 3s or certainly 4s and beyond, it's dilated. And there's many, many causes for a dilated aorta. But if there's a strong family history of what is clearly aortic dissection, and you have a post-mortem confirmation that family members are dying of aortic dissection, you're then talking about aortopathy, and the echo would give you a very, very good feel for whether or not this person is at risk. Having said that, you can see with the echo, you only get to see a little bit of the aorta, and so not uncommonly we would organise an MRI, especially if there's an abnormality, and you want to see the full extent of the abnormality. And so this MRI, this little bit there is the aortic root and the ascending aorta, which is what you're seeing on the echo. The echo doesn't see much more than that, whereas the MRI gets you a really good feel for the aortic arch, the neck vessels, the descending aorta, the abdominal aorta. These are the kidneys, and sometimes aortic pathology is not limited to the bit that you can see on echo, and sometimes patients have an abnormality somewhere down here in the descending aorta. Some family members seem to have it mostly in the abdominal aorta, and so an MRI is a very useful tool, and of course not as readily available, much more expensive, etc., etc. And so which technique you choose to evaluate will depend a little bit on a case-by-case basis. Dilated cardiomyopathy is as the word suggests. If you suspect that there is a dilated cardiomyopathy within the family, then dilated simply means the heart is enlarged. The heart is dilated, and this is a nice echo image, a 4-chamber view. This is your left ventricle, your left atrium, and what you see here is a very large left ventricle. And I haven't played the image, but what you'd see is not just a large left ventricle, but an impaired left ventricle. And so dilated is the word that means enlarged, and cardiomyopathy effectively means that it's impaired. And so what you have is a dilated and impaired left ventricle. And I only put the ECG up because one shouldn't lose sight of the fact that although you're looking at heart muscle for this disorder, there are associations, electrical abnormalities that might occur in this sort of condition. And so you always do an ECG as well. But once you see a dilated cardiomyopathy, that gives you a clue as to what's going on. It is worth remembering, though, that when you see a dilated cardiomyopathy, it does not necessarily imply that it's a genetic disorder. There's lots of causes of a dilated cardiomyopathy. One of the commonest causes is post-viral, or you might see it in a person who takes too much alcohol, or you might see it in a person who's had a prolonged arrhythmia and the heart dilates. And so if you see this in 1 or 2 members of a large family, it does not necessarily imply that it's genetic. It may well be, that one member had it for post-viral, another person drinks far too much alcohol, and so it's not specific. This is not the fingerprint of a genetic disorder. This is the fingerprint of a dilated cardiomyopathy of which a genetic cause is one of the causes. But not uncommonly, you'll find a family where you might find one has had a heart transplant, two are waiting a heart transplant, and others are walking around in the heart failure clinic, and under those circumstances, including young people, clearly there's going to be a genetic component to that disorder. The second type of myocyte disorder that I'm sure you're all familiar with is called hypertrophic cardiomyopathy. And where this is really quite different is that the heart muscle, especially the septum in this case, is very, very thick. So as opposed to being dilated, this is hypertrophic, and that's why it's called hypertrophic cardiomyopathy. This is meant to be the most common cardiac genetic disorder. The prevalence used to be thought to be, if you go back to the early days, the 1950s, when it was first described, it was thought to be rare and fatal. Then it was thought to be much more common and not always fatal. Now it's said to be very, very common, and the most recent data suggests just maybe genetic carriers are 1 in 200 as opposed to 1 in 500 thought more recently. And so as far as a genetic cardiac disease is concerned, this one is very, very common. I've just got 5 minutes before Warren talks to go through one case, and I wanted to use this example, which we hear quite a lot, not just from patients, but from GPs alike, and that is, can a cardiac genetic condition skip a generation? I'm sure most of you have either considered that or heard of it. And so this is an example of a young boy that I see. He's 15 years of age, he's very active and well, and his maternal grandmother, so his mother's mother, had confirmed hypertrophic cardiomyopathy. It was confirmed both during her lifetime and on subsequent testing, and there's no doubt that she had it. And this is a true genetic condition, hypertrophic cardiomyopathy. Now the boy's mother, the daughter of his grandmother, is now 48, and she's perfectly well. And she's had a normal ECG and a normal echo, and to all intents and purposes it would appear that although her chances were 50-50 of inheriting the condition from her mother, it would appear that at this point in her life she has no features whatsoever of the disorder. And so one might rightly ask the question, with regards to the 15-year-old boy, does a normal echo now clear him? He'd love to be cleared. He's a sporting chap, he wants to travel, he's got issues with insurance to sort out, and the question gets asked, well, if I'm normal and my mother's 48 and she's normal, do I get a clearance? And the question that his mother asks is, well, if she doesn't have it, as she's now been told, can he still have it? And these are very relevant questions. There are 3 very, very important considerations. The first is the concept of genotype versus phenotype. A genotype describes whether or not you are carrying the mutation that you know is the cause of the abnormality. A phenotype is when you actually express it. You can express it in this instance by demonstrating it on an echo, for example, or you might express it on an ECG. But also, strictly speaking, you might express it only on an MRI, which is more sensitive. Or you may not see it on an echo or an MRI, and if you're brave enough and feel the desire to do a biopsy, you might see something a bit funny going on in the septum that wasn't obvious on the echo or the MRI. Or, in worst case scenario, a person dies suddenly with all of these features having been normal, and a post-mortem shows unequivocal pathological changes consistent with the condition. And so what I want to get the message across is that when they say, do I have it, the real question is, do I have the genetic mutation that predisposes me to the condition? Question 1. Question 2, am I expressing it phenotypically? And the reason why I want to stress that is because if you took that family and you took the mutation in the grandmother and she expressed the condition, which we know she did, it is possible that the mother could have the genetic mutation and not yet express it. Now clearly when you're much younger, that's still possible. At 48, you start to think, well, gee, if you haven't expressed it by now, more likely than not, you're not going to. But the absolute reality is that you can clear someone phenotypically. The only way you can clear someone genotypically is to have the mutation data available, and Warren's going to give a nice case of that. And so what we try to do is get the grandmother to have a blood test to look for the mutations that can cause HCM. If you demonstrate the mutation that she has, you then look specifically for that mutation in the grandmother's daughter, and if she does not have the mutation, then neither she nor the son can conceivably ever have that condition, and then you can clear that family with certainty. And the last point I wanted to make before handing on to Warren is that clinical severity can be very variable within a family despite a known genetic mutation. and this is a concept that's not always taken up, and that is that if, for argument's sake, the grandmother, the mother and the son all had the same mutation, it's possible that the grandmother could get picked up purely incidentally, pre-bowel surgery, someone does an echo, sees HCM, she's 80 and she's doing well, as some of them do. It's conceivable that the daughter could have a more severe or less severe form, and it's even more conceivable that if the grandson carries the mutation, it's conceivable with all the other confounders and all the other mutations and other genetics that he might have, it's conceivable that the third person in line could actually manifest far more virulently and sometimes even with sudden death. And so you don't have the luxury of knowing how one person is phenotypically expressing to be certain that that's how the rest of the family is going to express phenotypically. So that's just one example, and I wanted to pass on to Warren Smith now to go through some other cases.
Bring that
Yeah.
Well, it's good that Ivor's ended on hypertrophic cardiomyopathy because, and some of you might have missed who came in slightly late, he started off showing an array of things that can cause sudden death. And he rightly said people die of heart attacks, but many people die of conditions that are not actually due to occlusion of the coronary arteries. But all these other things, the long QT syndrome, the Brugada syndrome, they're not common. Now the long QT may be the most common of those, maybe 1 in 2,000, but hypertrophic cardiomyopathy is 1 in 200. So it's something everyone's going to see in general practice. And I think it's worth just spending a little bit of time on the specifics, particularly if I can get this thing to advance. There we go. So here is a family, and this is the pointer. Yep. So the family history is terribly, terribly important. And hypertrophic cardiomyopathy, we should say, it's common. And why is it common? Because it's usually not harmful. The majority of people with hypertrophic cardiomyopathy live perfectly normal lives, but not all of them. There's a sting in the tail of sudden death. It's only 1%, but it's absolutely tragic, as Ivor alluded to, when it occurs. Someone who didn't know they had the condition, they're out running, and then they're found slumped against the fence post-death. So it's very important to diagnose. And so we construct this family tree. And we can see in this particular family that here's a young person in their 30s and was picked up with a septal thickness of 21 millimeters. Well, what's normal? What about if my son plays soccer? How thick would his septum get? Well, we think 13 millimeters. If it's more than 13 millimeters, we say that's abnormal. But of course, what if it's 14 millimeters? That's a pretty important diagnosis to lay on, say, a 16-year-old playing soccer. You're going to say, I'm sorry, you can't play competitive soccer anymore. His mother says, what? He's the captain of the team. And the psychological damage. So once we see a septum of 21 millimeters, we're pretty confident about it. But with lesser degrees, we like to follow it up with an MRI scan because it's such an important diagnosis. The echo is a wonderful screening tool and it's very accurate. And I might come back to it with some comments about its pitfalls, but we like to follow it up with an MRI if we're going to label that person and then undertake screening in the wider family, because here we can see this family, this particular family, it's a very bad family because this person, the mother, had hypertrophic cardiomyopathy, had atrial fibrillation, but lived a relatively normal life. And that's what Ivor was saying. The mother, it didn't really intrude in her life except for atrial fibrillation. Well, that's something that comes on as you get older anyway. I'm worried every day I have a drink now, maybe I get atrial fibrillation. But look at this. Down here, we've got, over here, this young boy suddenly died at 28, was said to have had a heart attack. And so even though it was relatively benign in the mother, it killed this person at a young age. And further back, we go back another generation, and here's a grandfather, died suddenly at 39. Very, very likely that there was hypertrophic cardiomyopathy. So just to stress, as Ivor said, just because we find it in one person and it's not too bad, we can't assume that it's going to be the same for the rest of the family, and we need to take a full family history and go back right to the grandparents. All right, let's move on. And so while echo is very good for diagnosis, the cardiographs often have normal and HCM, and if we see an ECG like this, with all this massive T-wave inversion in a young healthy person, 999 times out of 1,000, that's going to be the ECG of someone with hypertrophic cardiomyopathy, and before we even get the echo, I've made the diagnosis. So an ECG is very simple to do, always worth doing. Now, so in this family, we had the person who was referred, we had the brother dying at 26 years after going for a run, and that's unfortunately one of the triggering episodes of sudden death and hypertrophic cardiomyopathy. We saw this maternal uncle and the maternal grandfather. And the brother had a post-mortem, and normally you'd hope that that would be a trigger, but in this case it got labelled idiopathic cardiac hypertrophy. Well, what use is that? It didn't actually lead someone to say, we need to investigate this wider family. And so that brings us to the point of genetic screening. Now, genetic screening is a very valuable tool. In hypertrophic cardiomyopathy, we don't know the majority of the genes that cause the condition. But we can screen for about 10 or 12 genes, and we'll get a diagnosis in 30 to 40%. So it's not that high, 30 to 40%. What we will also find with genetic screening is that, yes, you can find a mutation that is unequivocally pathogenic. Or you can find some what we call polymorphisms that are present in the general population. Maybe 1% of the population carry them, and we can say they're benign. And then we get the hooker, which is the variant of unknown significance. There's a change, but what does it mean? And so you go to your text, you look up, has it ever been reported anywhere else in the world? And if it has, yes, we've found this in a family with a family with hypertrophic cardiomyopathy. You say, this is probably pathogenic. It's not quite got there, but it's looking suspicious. And then if you come to your family, you have a big family like we saw, and you screen everybody, and all the people with the condition have this variant of unknown significance, and everyone who doesn't have the condition doesn't, you can say, that's tracking. I'm going to upgrade this further and now say this is a pathogenic mutation. But it's important because when we do genetic screening, we do need to do some counselling. As we've said, it's a very important diagnosis, and it may have insurance implications, and it may have implications for sometimes employment, if someone's going to be a frontline police officer, or as now if people are playing competitive sport. So we give them some counselling, but in most cases it makes sense to undertake the test, and we say, look, we may buy something that we don't know what it means. And in that case, we'll just have to park it, and as time goes by, we might go either way. We might upgrade and say, yes, we've now made this a definite mutation, and we can offer screening to the rest of the family, or no, we've now downgraded it, it's nothing, we can forget about it. So genetic screening is worth doing, even though in this condition, it's only a minority of people that we're going to find an answer. And we can see in this particular family that it's tracked very nicely. So the people that have got the condition, and we can go back, if there's been post-mortem tissue saved, we can do genetic screening on that. Rarely we can do genetic screening from the Guthrie card. It's not quality DNA, but quite often diagnoses have been made from the Guthrie card. And here we can see that the people who don't show echo evidence don't have the gene. And that's handy too, because if we don't have a genetic marker, we have to screen people in puberty every year till they're about 20, and from thereafter every 3 to 5 years until they may be 50 or so, when the risk of coronary artery disease starts to exceed. And that's a burden. That's a financial burden, obviously, but it's a psychological burden, because someone's never quite free of, well, maybe I'm carrying this condition, and maybe I've got it and I can still pass it on to my children. But if we've got a gene, we can do the gene screening and say, you're clear. It puts everybody's mind at rest. And we came back, this was about echo, and I think it's important to have some focus on that. So I'm going to come back to Ivor and say, so Ivor, I get this person coming through, and the family history of some sudden death, I'm not quite sure what's going on. I get an echo, and it comes back 1.5 centimetres. Can I now feel absolutely confident I've nailed this down, this person's got hypertrophic cardiomyopathy, and I can launch myself into all these sorts of manoeuvres?
So if that isn't just a hypothetical, Warren, when we worked together at Auckland, often came to me with that sort of question. And so the first thing I would say to Warren, which I think is really important, whether you're in general practice or specialties, is say, let me go back and actually look at that raw data myself. Let's just be certain that that is actually 15 millimetres, because it's not a computerised printout. Some sonographer did the scan, and some cardiologist, maybe a tired one at the end of the day, put the number in, and the implications are enormous. It doesn't take long just to look at the pictures. Often we look at them together. And there were some occasions we looked at them together together and realised that the image was taken at a very oblique angle, and in fact what is probably 11 or 12 has been erroneously reported as 15. So go back to the raw data, it doesn't take long. If it looks like it definitely is hypertrophied, I think the ECG is very important. We'd look at that together too. If you've got 15 millimetres and an unequivocally abnormal ECG for no other good reason, you could be pretty certain that you're dealing with hypertrophic cardiomyopathy. Plumb normal ECG, 15 millimetres, athlete, or not an athlete, but an incredibly strapping person, everything about them just seems big, then I think an MRI would be the gold standard imaging test. Not that it's perfect, but it is better, it's more sensitive and it's more specific than echo. And it should be thought of as an additional tool and not the be-all and end-all.
Thanks, Ivor. And so it's important to come back to where we started, that for most people, it's going to be benign. So most people with this condition are going to live perfectly normal lives, but sudden death can occur, and in people that have got very thick septums, a 30 millimetre septum, for example, or someone that's had recurrent non-sustained ventricular tachycardia on their Holter, or there's a bad family history like that first family of sudden death, we can implant a defibrillator. And that's not a small thing to do, but it gives security, very, very good protection. So in that minority, we've got a very good treatment. Sometimes that hypertrophy, as Ivor nicely showed in his echo, obstructs blood flow out from the aorta, and we can treat that. We used to do a lot of septal myectomy, and now quite often alcohol is injected down the first septal artery to cause a controlled infarction and relieve that outflow obstruction. Sometimes with advanced heart failure, transplant will be an option. And as we saw with that very first lady that I showed you, atrial fibrillation is more likely. And once we diagnose atrial fibrillation, even if it's a 25-year-old, they need an oral anticoagulant. It's not your Chad's score. Hypertrophic cardiomyopathy is an increased risk of thromboembolism. Once we make the diagnosis of AF and HCM, we need to go to an anticoagulant. And so, take-home messages: family matters, family history, very, very important. We need to screen the first-degree relatives. At Auckland, there's the Inherited Cardiac Genetic Clinic, which Ivor works at, I used to work at. It's a very good service. You can refer to that, and they are very good at undertaking this wider screening. Once we've made a diagnosis in the family, we need to make sure, if we don't have a gene target, that we're doing regular screening. We'll stop there, and Ivor and myself will be happy to take any questions.
What about bicuspid valve, aortic valve? I'm dealing with two families. If I have a parent who has bicuspid, I understand that we have to screen the kids.
So it's controversial along two lines. Firstly, it's not a purely genetic condition the way these are. It doesn't fulfill a 50-50% autosomal dominant classical mode of transmission, and so the risk of the offspring is actually a lot less. So if you look at the general population, 1 or 2% of the general population will have a bicuspid aortic valve. And then if you look at offsprings or first-degree relatives of patients with it, the risk is going to be high, but it's nowhere near 50%. And so you have the situation where A, there is an increased risk, but not enormously so, and B, there is some emotion behind it, because not just the valve, but the aorta could be involved and could cause aortic dilatation, risk of dissection, and so forth. The bottom line is very difficult to rely on clinical acumen. What we've decided at Auckland Hospital is that rather than promoting each and every first-degree relative of every patient with a bicuspid aortic valve must get referred in for an echo, which is an almost insurmountable scenario for any public system to deal with, is that in the event that it's requested, we haven't turned it down. I haven't as the head of the echo department. Somebody later on may choose to do so. I haven't, because I think it's not unreasonable. It can be done very, very quickly, very, very targeted. And then if it seems to be more than just one family member, or other things seem to be in the waters, an ASD, a VSD, a bicuspid valve in 3 members, it's a little bit more. But you just we haven't got really a good resource to offer every first-degree relative of every patient with a bicuspid valve proactively saying, who are you out there? Come to us. We would like to screen you all. But we haven't turned it down.
And just about the blood pressure, the cardiologist said keep the blood pressure as low as possible, but there was no recommendation made.
Oh,
in who?
In a bicuspid aortic valve patient?
Yeah.
No, so
apparently there can be fragile?
No. So again, what tends to happen is that people tend to use a diagnosis and extrapolate as if it's the same for everybody. And so some bicuspid valves are thin, mobile, not stenotic, not regurgitated, normal aorta, and others are anything but. And so I've never had any recommendation with regards to blood pressure specifically to the presence of aortic valve, as opposed to a bicuspid valve with an aortopathy. And if you've got a dilated, or myofib, but if you've got a bicuspid valve with a big aorta, which is associated, then you recommend keeping the blood pressure where I would, towards the lower end of the normal range, but that's primarily to reduce the pressure strain on the aorta and less to do with it on the valve. Yeah. We've still got time for other questions if there are any.
Can you see that the fourth point, please, it ensures risk stratification performed regularly?
Yes. So, and that's a very good point. So it's important to talk to the patient. So one of the things is seeing your patient regularly and asking them whether there's been, for example, unexplained syncope. I mean, syncope is very common, and the commonest cause is vasovagal, but in someone with a family history of HCM or gene positive, we take syncope very seriously. If someone with HCM had syncope and we couldn't confidently assign a cause, we could even make a case for putting in an ICD in that person. So keeping up, as far as Holter go, we don't regularly Holter. We don't have a plan with everybody on our system to do Holters regularly. And so that's a weakness. There's no guideline, but I think it's important. In a younger person, I would do a Holter probably every 3 to 5 years. That's a very simple thing to do, although it's not regularly enshrined in practice. You know.
How on board are the insurers? You know, when a lot of these problems that we face with our insurance companies, and it's getting worse and worse all the time, there's increasingly grey areas in a lot of conditions. What's your experience of the insurance with HCM?
Well, one of the things is that you can't get away from the family history. So if we took that first family, it's irrelevant. Once you tell the insurer, well, you know, members of my family have dropped dead. Yeah, and so it's not often that it really comes up. Sometimes it does, and if someone's gene positive and otherwise well, you know, they may get a loading. But in practice, in the clinic, I used to run the hypertrophic cardiomyopathy clinic at Auckland. It's not a big deal, because the family history is there and the insurance company are entitled to that information.
I think it's worth saying it's an ongoing, moving process, and so whatever the case is today, I wouldn't want to bet too much as to how it's going to be in 5, 10, 20 years, because the information that comes through, as I said in the very first slide, both provides new information you didn't know before, but also what it often does is takes away information you thought was entirely certain and becomes less certain. And HCM is a great example. In the 1950s, it was really considered to be a fatal condition because the only people that were diagnosed with it were dead people. There weren't echoes and there weren't MRIs, and so you're dead, you've got HCM, that means they thought everyone with HCM dies. And as echo came around, and then MRI came around, then genetic testing came around, and then epidemiological studies came around, you suddenly think, well, hold on, 1 in 200. Most of us are blissfully unaware of it, or so minor we don't even know we've got it. And so the whole paradigm of it has shifted. And so whenever we do genetic testing or see these patients, I, for one anyway, have a very loose hat on my head as far as trying to be certain how things are going to be in the future. Yeah.
In terms of the exercise you're going to do, I'm assuming they go into VT or VF with exertion. Is there anything they can do? Bearing in mind to do something.
Yeah, so what we advise against is competitive exercise. I think it's a combination of physical exercise and mental exercise. So I say to them, I don't want you running half marathons, I don't want you doing cross country, I don't want you competing, but you can exercise normally. In a supervised gym program, I do not stop people with HCM doing that.
That includes weights.
Yeah, I'm not so. I'm not happy about. I wouldn't have people doing heavy weights myself. I wouldn't. Amongst other things, it puts the blood pressure up very quickly. I think you have to pay some respect to the condition, but it's extremely important that you allow people to develop as normally as possible.
Just very briefly on that topic, we've got to go, but I had a patient who was a top-class sportsman, late in the high school career, diagnosis with this condition, 4 centimetre septum, lots of scar tissue in the MRI, very high risk for arrhythmia, got an ICD. He could not play top-class sport, it was out in the ocean, in the water, the risk of death. Life fell apart, in many, many ways. 7 years passed with an ICD, and he got his first shock 2 weeks ago, having lunch, eating a sandwich. And it's just a salient reminder that with all the risk stratification in the world, and all our best knowledge and best advice and best intentions, his life would have ended without the ICD having lunch, and never ended with him having not taken my advice and running around and doing things for the last 7 years. And so we try to make broad recommendations that are reasonably sensible and probably appropriate for most. But individual cases and individual families can really let us down quite badly. And I do try and stress that when we're recommending all of these things, it's with the right intentions and so forth. The warrants is to be very, very careful not to cull a person's life entirely, because the true risk of sudden death actually includes sleeping, eating sandwiches, watching a movie, and playing sport.
A very broad recommendation to go to room 1.
Thank you.